there are many people who are developing this disease. So there's a small organ in the just below the bladder. It's a small organ. It's maybe some less than 5 centimeters in some men. That organ is called the prostate. That organ is not visible. You cannot see it. It's not like these other organs, the breasts that are open. This is a small, tiny organ, but very important. It plays a role in reproduction. That is its main role in reproduction. So men who are in that age group definitely have an active prostate. It's difficult. If you don't have a prostate, it's difficult for you to have children. You won't have children without a prostate.
Is it possible to have
it? Sometimes some men, it may grow, but grow abnormally, so it becomes smaller. All right, just like it's possible to grow without a kidney. You find some people have one kidney for some reason, but you cannot have children without a prostate. So the prostate has a big role in reproduction. It produces some fluid. The urine exits the bladder through the prostate and then through the urethra. So everything is covered in there, in that, genital area. That's why everything is hidden. So sometimes when you explain to people, they try to imagine, where is the prostate? Visibility is very important. And good. So this is an image. This is a cross section. So imagine that you've been split into half. This is how your body looks like. This other area is the rectum. So if you note very carefully, it has proximity to the prostate. This yellowish organ is the prostate. And this is the bladder. Okay? And you can see how all this is connected, how your testis is connected. That tube comes through there and goes around and comes through the prostate. And that's the fluid we're talking about. And then you see how the urethra exits there. All right. So most times there are also, I should say this, that the prostate also has some small organs that are attached to it. These are called the seminal vesicles. They do the same process of reproduction. And the doctors normally will feel for your prostate via the rectum. So the doctor puts a finger here and is able to feel the prostate. Yes. So when we're examining the prostate, that's our route of examination. That's how you can feel the organ. All right.
That's why they say it's painful and maybe.
Well, it's uncomfortable and it requires privacy. Just like when we are examining women's cervix, this is the same kind of story here. You require privacy to be able to examine a man's prostate. So when the doctor puts his finger here, he can feel the prostate has 2 lobes, and he can feel whether this prostate is enlarged or smaller or sick. When it has nodules, sometimes when it is sick, it has nodules and it's bumpy all over. So the doctors use that technique to be able to examine the prostate. So it becomes, as you grow older, it becomes enlarged. All right. So when it becomes enlarged, because of its proximity to the bladder, then men start to have issues of urinating frequently. So most men who are above 50 will have a bigger prostate than men who are below 50 years. And most men actually just have enlarged prostates without cancer. But the symptoms are very similar. They are all related to passing urine frequently. Okay? Yeah. So that is what we call the prostate. It has a role in reproduction. It is hidden away from the eye, but it's proximal to the bladder and to the rectum. And when we're examining, we have to access it through the rectum to be able to feel and see that the prostate is enlarged. The other, which is very important, is your family history. So Generally speaking, most experts believe when you have a family history of prostate cancer, your risk is almost 25% higher. If you have more than one relative, or for example, in a family, the father has prostate and the son has prostate, the other siblings, their risk will even be 50%. So you can have a family where there are more than 3 people. The father has, another son has, another son has. The risk of the other sons getting prostate is much higher, and those are considered high-risk groups. So family history, very important. What about diet? Generally speaking, diet is a risk factor for cancer. People talk about processed meats. Processed meats, as opposed to just red meat, processed meats have a high risk of cancer. And these include things like sausages, meat pies, and all these things which are packed and frozen for you to eat. Okay? People have talked about red meat, but generally doctors not discourage people eating, not to eat red meat, but what we discourage is too much of it. Too much. So we say reduce. And then also we focus on how much fat is in your meat. Okay? So we don't say don't eat. There is no recommendation saying don't eat red meat, but reduce the red meat significantly. If you are to eat less frequent, non-fatty, okay, portions of the meat, okay, so that you cut down your risk. What about things like alcohol? Generally, alcohol will increase your risk of almost many diseases, including cancer. If you take too much alcohol, your kidneys can die, your liver can die, your pancreas can die. So is cancer. So too much alcohol, your cancer risk. The more the bottles, if you imagine 1 bottle, 2 bottles, 3 bottles, the higher. And then also the type of drink. For example, if you're taking these very strong drinks, you've heard of the whiskeys, the dry gins, those even have higher, the risk goes up. The lower alcoholic drinks, the lower the risk. The higher the alcohol in the drink, the higher the risk. The bigger the number of drinks, the higher the risk. So generally, there are 4 main stages. Generally, across the cancer, many cancers, we have mainly 4 stages. Many solid tumors, 4 stages. Stage 1 and 2 are considered early. For example, in prostate cancer, when you have stage 1, the tumor is just in one location, one lobe. When you have stage 2, it's probably involving 2 lobes. 3, it is almost exiting the capsule, the covering. And 4, it has exited and gone to other places, of the abdomen and gone to the bones and all other organs. So stage 3 and 4 are considered late. Now, for men who come late, of course, cure is determined by the stage. It's the stage of disease that determines who will be cured of the disease, who will respond to treatment, who will do well generally. If the stage is late, the disease is going to come back even after you've been treated. Okay? The disease will not be cured. It may be controlled but not cured. That's the challenge. So we want men to come early, but you cannot come early if you're not in the know about how this disease manifests. That's why we are campaigning to teach you how to understand how this disease is a silent disease. You may have no symptoms, for example. Let's focus on the symptoms now. So many men with prostate cancer don't even have symptoms, but the age will tell you that no, you need to go for a check. Are you 50 years and above? Are you 40? Do you have a family history? You need to come early. If you have a family history, by the way, those people tend to come early for reviews. Now, because it has no symptoms, or the symptoms are vague, they are there, but you don't understand them. There is a man who, for example, who just had erectile dysfunction. It's one of the symptoms of advanced prostate cancer. You're not functioning well, and that can be a big problem, and you don't understand what is happening. You need to have a check. You need to go to your doctor and be checked properly. there are people who start having symptoms we call irritating symptoms. Symptoms, because of this picture I showed you, proximity to the bladder, the symptoms irritate the bladder. And these symptoms that irritate the bladder will result in you frequency going to pass urine frequently. For example, each time you're going to pass, before you reach the toilet, the urine is escaping. We call that urgency. When you go to the toilet, you hesitate to pass urine. You have to go back like 2 times before the urine comes. The urine flow speed has reduced, or you're dripping. You just drop, instead of the urine pouring, you're dripping, okay? Or you have to wake up like 10 times in the night to pass urine. These symptoms are also common in people who have enlarged prostates, but generally, should you have these symptoms, do not stay at home. Please go and see a doctor. Go be checked. Even if you don't have symptoms, are you 50 and above? Are you 40? Do you have a family history? Please go see a doctor. The late symptoms, by the way, you may see urine in the bladder, in the blood in urine, or you may have bone X. That is when the cancer has spread to the bones. For some reason, prostate cancer commonly spreads to the bones. So there are people who have gone to the physio to check your bones. The physio has been working on you for many months, and if you're a young person, the prostate can be removed. But remember, we say that once they get the prostate out, your reproductive function is affected, because we say the prostate has a role in reproduction. So once the prostate is removed, reproduction is affected, all right? And also sexual function will also be affected. The other treatments we have for prostate cancer include hormonal treatments, include radiotherapy, include chemotherapy, include a number of biological treatments, newer kind of treatments that are available. All these treatments can be availed. We have radiation, we have all these other hormonal chemotherapy treatments. Surgery can be done locally for many patients. Our surgical colleagues who operate on these patients are quite loaded with men with these same problems of the prostate. Basically, it's a big burden. It's a big burden disease, and it's a challenging disease. It may affect sexual function, but you would not consider it infertility as such. But it may in one way or the other, because one of the treatments for prostate cancer, in some cases, the doctors remove the testes, and that can affect the fertility of a man. Yes. That was a new study that was published a few weeks ago, and it's created a lot of excitement among people. But medically speaking, when there is one study that shows something new, it needs to be duplicated elsewhere to be taken up as medical truth. Whether that is so, there are other men who develop, cancer, whether they do ejaculation or not. The other risk factors are still a big problem, okay, like family history, age, for example. We know that for many men, once you clock the age of 70, 60 and above, there are many men who have tiny cancers in their prostates, although those men don't really require to be treated. Okay? Just to give you an example that this is a very common disease. So regardless of whether that study has any proof, we still know that there are other risk factors that will probably lead to prostate cancer. So I think it is much bigger than just what that study showed, and it's a much bigger challenging problem with many risk factors. We have, UCI has maintained free screening services that run every week. The services are free. We serve our population, we serve our people here, because we know our people can't afford some of these services. The basic services are available. You will be able to speak with a nurse, you'll be able to speak with a doctor, You'll be examined by a doctor on a daily basis. Should you have any concern about cancer, you want to speak to a doctor, come to Cancer Institute. We have screening services. However, screening services are people who are normal, not people who have symptoms. When you have symptoms, you need to see a diagnostic service. You need to see a doctor to make a diagnosis. But when you are normal, those are the people meant for screening. People must have no symptoms, they just want to check. So these services are free. To see a doctor for screening is free. You don't pay money. We have an ultrasound if the doctor needs to order. We have an X-ray if the doctor, at least the basic tests. We have the basic laboratory tests that you require as an initial screening tool. So all these services are available. However, it's difficult to imagine somebody coming from another country to come all over here. That's why there is an effort to spread the service in regional centers. We have a clinic there. It's called the Uganda Cancer Institute Clinic. We have patients, we have doctors, we have staff. That is one of our model clinics we have set up. The other area where we have a clinic is Arua. Okay, our presence is growing there. We have plans for Gulu to cater for the northern part of the country, and we have plans from Bali to cater for the eastern part of the country.
So far you have 2.
So far we have 2 which are active. Those other 2 are coming on board, so we shall have 4 regional centers in the next few years.
People have to travel and come this way.
People have to travel, but also in the past year, for your information, we trained in every region. We went to every region. We trained the medical personnel about symptoms of cancer and referral systems. Okay? They have booklets about different cancers, how the symptoms manifest and that kind of thing.
So what other cancers do Ugandans need to know?
Focus on the most common cancers. Okay? If you look at women, cervical cancer is still a big challenge. Almost 4,000 women every year. Yes, this is big. And look, the country has a program to vaccinate young girls against this virus that causes this cancer. But the uptake hasn't been very good because I think information needs to go out. But young girls need to be vaccinated against this deadly virus that causes cervical cancer, the HPV virus. So there is something that can be done, but the uptake is still not so good. So we need to increase awareness among the people because cervical cancer continues to be a big burden in Uganda. Number 2 is breast cancer, which is a big burden among women in Uganda. It's the number 2 cancer. So these are cancers. For the breast, it's an organ that is exposed on the surface. So if we teach women how to examine their breasts, which we are doing, we hope that every woman takes opportunity to check her breast. After all, many women who eventually come for care have found the lump in the breast by themselves. So, but how often do you do checking? That's the other question. And then among men, we mentioned prostate cancer, and then there is Kaposi sarcoma, the cancer that is associated with HIV. It's still a big problem because there are many people who are HIV positive and do not even know their status. Eating more fruits, vegetables, as compared to meats or red meats, cutting down on those will probably also cut down your risk. Obese or overweight is very important as well as a risk factor, as a way of cutting down risk. Then there is also fat per se, too much fat in your body, generally leading to obesity and then leading to what we call NCDs. The other thing is actually screening. Screening is you go to see a doctor. If I was a man out there listening to this program and I'm 50 years, I would make sure I go to see a doctor and make sure I know the status of my prostate, because it's just too common and it's becoming increasingly common than before among men in Uganda. I will make sure I go to a hospital and they check my prostate. They do a scan, they check my blood, they examine me properly, see whether my prostate is healthy, and then I'll be comfortable. But also keeping healthy practices. There are many practices that we do that can endanger us. If, for example, you acquire a viral infection, that can also increase your risk of cancer. So HIV per se can also increase your risk of developing any type of cancer. There are those cancers that are common in HIV patients, but also non-HIV associated cancers can affect you once you get HIV. So HIV per se is a risk for cancer, generally speaking. Government-run institution, and our treatments are free of charge. Our policy is government buys the drugs for Ugandans. So once you're Ugandan, you're entitled to free treatment. Okay? Many Ugandans are probably not aware, but we encourage them to come over. The drugs are free. As long as they're available, you get them for free of charge. And we plan for Ugandans who get sick to come and get treatment here.
Then that helps, because we've been hearing a lot, there is no treatment, they make us to buy. What
I think sometimes it's the press. It sells more to make big news, of course.
No, that we just hear people.
Yes. Even the patients.
The patients who say that.
No.
At hospice.
No.
This. Go with prescriptions.
Now look, this is what happens. Is there are instances when there are stockouts. That's normal for any. Okay, and the way government procures drugs is a procurement process. So there is a plan, drugs are procured, but sometimes procurement depends on the budget as well. Okay, but we don't expect that all the drugs will be available at any one point, but most of the drugs. You may find sometimes you have stockings of 50% supply. There may be one or two drugs which is not available. We expect that the patient or the family should be able to procure that drug. But this does not happen all the time. So when the patient comes in and there is no drug, it is not all year round. It may be for that specific period when the stock out is happening. Yeah. But we try to procure major drugs that cater for most of these diseases I've been talking about. All right, like say our big problem is prostate cancer. We make sure we know the numbers that come in a year and we add in, so we procure that. But sometimes procurement may be quarterly, and in the end of the quarter maybe we haven't received the supply. So in that period we may have a stock out, but it's not constant. But when it's reported in the news, it looks like it's an all year round thing. No, that's not how it happens. Yeah, but stockouts are normal. They are normal. They occur. They are normal things. Yeah, but normally we try to provide for most of the major diseases. So you may find also patients who have rare cancers that are not common. So we budget based on our bulk of patients that come in. So if you have a rare cancer, and we see maybe one or two patients, they need a unique drug, we may not have that in stock. So those are rare cases, situations. They happen, and it's normal. Yeah.